Thank you for that, and good morning to all of you. Really excited to be here this morning to talk to you a little bit about some of what we're doing. And just as a show of hands, how many of you guys are familiar with the CMS Office of Minority Health? A couple. Okay. So good. A lot of, obviously, with your funding from ARC and with PCORI, I think a lot of people are familiar with the work that ARC's been doing. But wanted to just take you through some of what we're doing and where there may be opportunities to engage, because we do try to utilize a lot the patient voice and make sure that, as our administrator says, we're putting patients first and trying to incorporate them in the work that we're doing. So, as you may or may not know, as a result of the Affordable Care Act, there are now a number of offices of minority health within the department. So we all work collaboratively, but we report to the heads of our respective agencies. And prior to the Affordable Care Act, ARC, NIH, CDC, HRSA, all had offices of minority health, and of course the one in the Office of the Assistant Secretary of Health, which was started over 30 years ago. So we, SAMHSA and FDA, are what I like to call the new kids on the block. I've now been at CMS for 7 years, so if you haven't been at CMS for 10 years, you're still new. So I still have a little bit to go, but we're getting started and engaging in a lot of our work. And we focus on a number of populations within our office. So we focus on racial and ethnic minorities, sexual and gender minorities, people with disabilities, as well as rural communities. And our work is largely organized in our framework for health equity that we call our kind of path to health equity. And that really includes three things. So what we can do to increase our understanding and awareness of disparities and their causes, how we can develop and disseminate solutions, and then through ourselves and our partners, implementing sustainable action. So as I like to say, that's getting into the standard operating procedures of the agency and the work that we do, so that long after I've retired, the work continues, and that it's not necessarily something that is funded or has to be funded in order to keep going. So that's really what we think about. I'm going to go through some of the things that we're doing. We don't have, I don't want to spend all day here, so I shouldn't say that. I do want to spend all day here, but you don't want to listen to me all day. So a lot of what I'm going to talk about is on our website, along with a lot of other stuff that I'm not going to discuss. But you can sign up and learn more about what we're doing and explore. And I'm going to focus, since this is a group focused on evidence, on how we are looking at data in particular and trying to increase the foundation in our ability to understand what's happening and look at disparities across a variety of populations. So one of the first things is a tool that we've developed, which we call our Mapping Medicare Disparities tool. And this is, you'll find that on our website. It allows you to drill down to the county level to compare outcomes for prevalence rates, mortality, utilization, costs, PQIs, of prevention quality indicators, for a number of conditions by race and ethnicity, by dual status, by age, and to see what's happening there. So as an example, this just shows you, and I was in New York last week, so looking at black-white Medicare disparities by county. So in Queens County, New York, if you were to look at this, it shows you, I've compared black to white Medicare beneficiaries. So in the black beneficiaries group, which is that top one there, the primary group, 8 per 1,000 beneficiaries have diabetes. And this was actually hospitalized for diabetes as opposed to just having the prevalence of it. Compared to 3 per 1,000 white beneficiaries. So that shows you the difference. And what I point out here as well is that when you look at this, you get a trend view, so you can look at the data over time. You get a county profile, so you can figure out how Queens compares to the national demographic population by a number of things, as well as the state view. And then last fall, we added the hospital quality data. So the purple dot there was Jamaica Hospital, which is where I was, and that shows you the other red dots are the other hospitals in that area and in that county. And this was comparing hospital readmissions, 30-day readmissions. So what that looks like is the red dot is then that hospital that you're comparing, and the blue bar is the other hospitals. Sorry, the red dot is the average for the hospital group, and the blue bar is that particular hospital. So you can see for a couple of the indicators, which is the readmission. The first one is the readmission for AMI, acute myocardial infarction, that rate is higher than the average for the other acute care hospitals. But they are lower if you look to the far, not the orange bar, but the one right beside it there for other readmission measures for heart failure. So that's some of the data that we've provided and allows you again to look at that granular level. You can compare hospitals that are acute care, you can compare critical access hospitals for those that are in rural areas, as well as we have the data in the counties that show you which ones are rural versus urban counties. We also started looking at our Medicare HEDIS and CAHPS data. This is quality indicators as well as patient experience measures, and this we have been working for a couple of years now with our Center for Medicare to stratify the data by race and ethnicity as well as by gender. And in November of this past year, we also did a rural-urban comparison to look at rural-urban disparities as well as rural-urban racial and ethnic disparities within the Medicare Advantage plans. So this just summarizes some of the findings from last year's report. This year's report was just put out, and you can find that on our website as well. And some of what the data looks like on the inside, it very much models after the National Healthcare Disparities and National Healthcare Quality reports that are put out each year from AHRQ. So we tried to align in sort of how people think about it and look at that so that if they're familiar with that, this is something that will look familiar to them as well. So you can see the blue bar are the indicators, the number of indicators that we have for clinical care where the particular group fares worse than whites. The green being that where they fare better, and you can see for men and women there's difference by race and ethnicity. We also produce each year the contract level data. So you could go in and again, just because in New York, sort of looking at diabetes quality, you can see for each of the particular contracts that are offered in Medicare Advantage what this looks like for diabetes, sugar, eye exam, and kidney disease monitoring, and the other indicators. What we always note, and one of the challenges in doing disparities work, is that we can't always report due to sample sizes for some of the population, so that's why you're going to see the not available. We suppress the data to make sure, for privacy reasons, that we're not accidentally identifying any individual. But you can see where there are some that we have doing very well on the blood sugar testing and maybe have room to improve on some of the other measures, for example, the eye exam. So this is data that's available also on the website when we do the release. One of the other things that we think about a lot is how do we build that business case for health equity? As I like to say, disparities research is never well funded or well staffed. So it's always a small team that's doing some seem to agree with that one. It's always, kind of a small team, but how do we do that? And so, because it's so important, because when you think about your ability to have an impact, if it's a 2-person team or a 5-person team and you're trying to impact thousands of people or millions of people, what is the reality of what that impact really looks like? So one of the things that we have developed is what we call a disparities cost calculator. And this is built on general sort of data from our Medicare population, looking at the cost associated with these conditions. And there are a number of conditions that you can look at and compare. For example, hypertension. And using a population distribution that is averaged across the normal population, or if you're an organization and want to put your own population demographics in there, you can do that. And you can see what the total cost of the disparities are for these conditions. In short, if you didn't see the differences, what you could potentially expect in savings. It's an estimate. It is not meant to be a very fact-oriented one, but it is an estimate that can help start conversations within organizations about potential costs. Because as we like to say, moral suasion hasn't worked in 400 years, so maybe we try something different and talk about the costs associated with disparities. We also have done a lot looking at language. And so we all know that there are more than 62 million people in the country who speak a language other than English, but 25 million of those individuals speak English less than very well. And the language is also local. So some of what we have looked at, these are the top 10 languages that are spoken in the U.S. other than English in a home. And I note that we also, when you look at, for example, the Medicare population, those languages look a little different. And so we did some analysis looking at those languages. And so on the far left, you'll see that that's what they are in the U.S. And so just flipping back for a second, you see that Russian is number 9 on this list, but it's higher up on this list. And similarly, Italian is not on the national list, but it is one of the top languages for the Medicare population. And then what we show in the report is also by state how that differs. So the red languages are ones that are not in the top 10. And you can also see that the proportion of the population that differs in terms of that with limited English proficiency, showing the top 4 states and then one of the bottom states in terms of the smallest percentage of the population with limited English proficiency. What's also interesting about this is that for Maine, what that shows you, that bottom gap there, those dashes, that means that if you translated materials or provided interpreters in these 9 languages, you would capture 100% of the population that has limited English proficiency. That is not the case in these other states, and so California being one that is so varied in terms of the languages that are there. But it's also interesting to note that when you look at the role that Spanish plays, so in Maine, Spanish is not the first language, the most popular prevalent language, nor in Hawaii. But in Texas, if you translated or provided an interpreter in Spanish, you get 84% of the population in Medicare that has limited English proficiency. It's a lot smaller in New York and in California. And then as you see for Maine and Hawaii, Hawaii doesn't even have it, but Maine, it's a lot smaller on the list. So we also talk about what providers have been doing, because having the patients, it's how are providers meeting these needs? And so we did a survey of providers and asked them about some of what they're doing. Do they even know how many of their patients have limited English proficiency or would prefer to have services in a language other than English? How do they capture that information? And as you can see, the key takeaways from this report is there's a lot of room for improvement. A lot of opportunity here. Only 10% are tracking the patient language preferences in medical records, which means each time a patient goes in, you have to start the conversation over again, or forget going in. When you call to make the appointment, you're starting that over again as opposed to having that information on hand. But even only a third of those are asking about patient preferences for language at intake. So again, thinking about quality of care and health outcomes, how are we communicating with these individuals? And this was not limited to the Medicare population. This was for providers regardless of whether or not they're serving patients, Medicare, Medicaid, commercial, uninsured, whatever. And then as you see, 16% don't know how their organization identifies or plans to meet patients' language needs. So lots of opportunities. In one of the other things, and Janice knows, our colleague in Leandris and CDC, Office of Minority Health and Health Equity, we collaborated with them and did an analysis looking at racial and ethnic disparities within rural communities. And when you think about, sort of what the kind of stereotype of rural America is, we sort of think about the Marlboro Man. We don't think about the diversity that is in rural communities. And there is growing diversity, particularly among Hispanics and Asian Americans. If you look at the change in the 2000 census to the 2010 census, the growth in rural communities was largely driven by those two population groups. So as you can see, the same reason we do all of this, if you just look at the average, you get one picture. But when you start to drill down, you see variation in that, and this just is one example of those who have not seen a doctor in the past year due to costs. One of the other things that's particularly interesting is, we think about our rural communities as being older, sicker, non-Hispanic, white, and this shows you that when you look by racial and ethnic populations, there's a lot of variability in what's going on, and particularly among the Hispanic population and Asians and Native Hawaiians and other Pacific Islanders. So 2/3 of Hispanics in rural communities are between the ages, adults that is, 2/3 of adults in rural communities are between the age of 18 and 44, compared to 37% for white, and also you see 61% of Asians and Native Hawaiian and other Pacific Islanders. And why this is important is you think about what are the health needs that someone has between 18 to 44 as compared to those who are 65 and older. When you think about 18 to 44, those are reproductive years. So for our rural women, access to care, maternity care, and other services for maternal health. We heard already a little bit about the social determinants of health. I apologize for the font on this, but the point that I want to make is similar to the conversation on health equity, we're not all talking about the same thing. So these are just a couple of the frameworks that are in use within the Department of Health and Human Services around the social determinants of health. So starting on the far left, you'll see the Accountable Health Communities model. That is a screening tool from our Center for Medicare and Medicaid Innovation that is looking at the connection between social determinants and health outcomes. And as you can see, the focus there is on food insecurity, interpersonal violence, housing stability, transportation, and utilities. And there are some other optional fields that the participants, the grantees, can capture. You have the National Academy of Medicine's framework that they developed as part of the impact report and analysis they did for the Assistant Secretary of Health. They have a few more in there looking at acculturation, dual eligibility, neighborhood deprivation. You have Healthy People 2020, the ICD-10 codes, which are the Z codes that are in social, and these actually are just the larger buckets. The Z codes actually have a lot more granularity in there. And then you also have the Prepare tool, which is developed by the National Association of Community Health Centers that's utilized by quite a number of the FQHCs, the Federally Qualified Health Centers. And then Health Leads is another tool. And so one of the things that I also point out with this is when we're talking about the social determinants, not always do we include race in that conversation, race and ethnicity. Some of these frameworks have it, others do not. And so one of the concerns that I have is as we're moving forward with this conversation that we may inadvertently leave out race and ethnicity. And we've seen over years of evidence that accounting for a number of these factors often causes disparities to shrink. In some cases disappear, but not always. So it is important that we continue to keep a lens on race and ethnicity. The other thing is that we don't have great data for a number of those, and this is just from the National Academy of Medicine's framework, and it basically is the greens are, we have data we can use now, and it's good to go. The lighter greens, we have data that's available in some cases, but we still need to do a little bit more, and red is where we have no data and still need to understand that a lot better. The other thing is we don't all capture this the same way. So even if we were to just take housing stability as an example, there is, the Veterans Administration, do you have a place to sleep tonight? Sort of that kind of aspect of it. Or are you concerned about losing your home or not having a place to stay in 6 months? Then there's also the quality of the home. Do you have pests, mold, other environmental toxins? All of those are kind of how we capture housing stability. But when you're trying to look at comparisons across the way, it's challenging. So some of what we've been talking about is how do we do that in a more standardized way to kind of understand both the relationship between these outcomes and these measures and health outcomes and costs, but also so that we can have a little bit more of an apples to apples comparison. So what we just released, today's Friday, 2 days ago was World Sickle Cell Day. And so we released 3 reports that we have highlighting some of the use of these opioids, but also just characterizing the population. Why this is important, so for the 2 highlights in the back, the prevalence of sickle cell disease among Medicaid beneficiaries. This is the first time that national data has been released on estimates of the sickle cell population in Medicaid. We have not been able to do that before, and so we're pleased to provide that information. We also looked at Medicare, our fee-for-service population, and some of the beneficiaries there. And then we don't do data just for data's sake, but we try to do data to think about, as you're looking at, how does that evidence inform decisions and policy making? So one of the things we all know, there is an opioid crisis in our country, and we have been working very hard to try and minimize the impacts and also minimize the opportunities for individuals to misuse opioids. So putting restrictions on the amount of opioids individuals are able to get as a new prescription and so forth. one of the concerns that we have is thinking about what does that mean for populations for whom it is appropriate for them to be utilizing opioids, such as sickle cell patients, those with other chronic pain conditions. What's happening to them as this is going into effect? So this first report was looking at opioid prescriptions in the front report, I should say, as opposed to the first, is looking at opioid prescription utilization among patients with sickle cell. But more importantly, we're comparing them to patients in hospice and with cancer. And the reason we do that is because in quite a number of our policies, that group, cancer and hospice patients, are exempt from the restrictions that we put on. So we wanted to show what does utilization look like among sickle cell patients relative to those two populations. Spoiler alert, it's comparable. And that maybe we should be thinking about, and as a result of some of the early work that we did, our colleagues in our Center for Medicare through the Medicare call letter that just went out, did add in there that plans should consider exempting this population similarly to the way that they do cancer and hospice. So that's an example of how we try to really use our data to inform policy, and data matters. So then the second part of our path is, I'm going to go quickly through this, developing and disseminating solutions, because it's great to identify a problem, but what are you going to do about it? So we launched our CMS equity plan for improving quality in Medicare. This was done through listening sessions that we had across the country. We did 5 of those, and talking to a variety of stakeholders and consumer groups as well about what they felt we should be focusing on. These are the 6 priorities that came up. I will tell you, number 6, increasing physical accessibility in healthcare facilities, was not on our list. When we went into this, we knew there were data. We talked about some of the other issues, but the physical accessibility was not really one that was on our radar. And we heard in several of our listening sessions that there really was a problem. And the problem is not, is the door wide enough for you to get into the office, but can you get in to the exam room? Do you have, if you're in a wheelchair in particular, is the exam table one that can be raised and lowered so that you can be appropriately examined, or are you not getting an exam? For example, if you're a woman, are you not getting a pap smear because you cannot get into the appropriate condition? So this is something we've taken on and have been doing a number of things in. We also have been developing a number of resources that we call building an organizational response to disparities. So a number of organizations we find they want to tackle the disparities once they've identified them, they just don't know what to do. So we've put together a number of resources such as a guide for reducing disparities in readmissions, providing language services to diverse populations, increasing physical accessibility, as well as a guide to developing a language access plan. So again, going back to those data that we looked at where we identified issues, how do we address these and provide some resources to help move forward. We also have thinking about our beneficiaries and our consumers. And so we launched our initiative From Coverage to Care. Internally, we like to call this the So You Got Health Coverage, Now What project. And originally, this was one that we developed in support of the marketplace when this was being launched, because if you think about who the uninsured were back in 2013, half of them were a person of color, half of them hadn't had health insurance for more than 2 years. Almost half of them didn't have a usual provider. I could go on and on, but the notion that you're going to give these individuals an insurance card and they're going to figure out how to navigate this very easy healthcare system that we have, I think left a lot to be desired. So again, we went out, talked to a variety of groups and did some listening sessions and said, what are you planning to do once these individuals get coverage? What do you think the challenges are going to be? Where are the gaps? And as a result, we developed, at the top, you'll see the roadmap to a better care and healthier you. And since then have added a number of other resources. The one in the forefront here is the roadmap to behavioral health. We developed that with the SAMHSA Office of Behavioral Health Equity. We've also translated these materials in a number of languages, working with community groups to make sure that the translations are culturally appropriate. And we, again, using our data, translated not just kind of willy-nilly into whatever language we felt, but looking at the data from our call center to see what were the most frequently requested languages, use that to guide our translations. All of these resources and others are available for free. You can order those. The roadmap also allows you to customize and add local information about your community group or other organizations in the area. We also have been working with the Federal Office of Rural Health Policy on chronic care management campaign to inform both providers and beneficiaries about the benefits of chronic care management and the availability of these services, particularly from the provider standpoint that they can get reimbursed for doing them. And that for others, that the beneficiaries, how that can help them in managing their disease. So there are some resources you can also access. And then we launched last May our rural health strategy. And this was, again, in that listening that we did. Listening sessions, we had, I think, 14 listening sessions across the country in rural communities, including like Pocatello, Idaho. And we did 2 with our beneficiaries to, again, think about where are those areas of opportunity for rural health. And so these are the 5 that we came up with and have been building on that. We actually were here in this room last Wednesday for a conversation on maternal health care in rural communities. We were really pleased. We had filled the room with about 200 folks and then had another 700 who joined us virtually to kind of go through the issues, talk about some of that path forward and identify where there are potential priorities and opportunities. We did that in collaboration with one of the folks you guys had up there at AFP and ACOG, as well as the National Rural Health Association and our other partners. And so keep watching this because more will be coming from that. And then we also offer health equity technical assistance. So this is free services that are available for organizations who are trying to figure out how to address their disparities. Can be as simple as, do you have resources on developing a language access plan, to we're trying to embed a focus on health equity into our strategic plan. Would you mind taking a look at some of what we're doing? So that's how you can find out about that. And then in the implementing sustainable action, since I only have like 3 minutes left, we've really worked to embed health equity throughout a number of our programs. The Accountable Health Communities model is one of those in which each applicant was required to do a health resource equity statement to show what the disparities were, how they planned to monitor those as the model was being implemented, and what sort of real-time process improvements they were doing. We did that because previously, until we put that in, we had to wait until the model was implemented to see what the impacts were, as opposed to being able, while the model is happening, to talk to the participants and see what's going on and what those challenges are. We have our Hospital Innovation Initiative Network, which is focusing on improving patient safety. All of them are required to focus on disparities and to submit a disparities action statement that they're going to be doing. Similarly, with our quality improvement program, the QIOs, they also submit quarterly reports to us on what they're doing on disparities, and then these other programs that we have focus on disparities. One of the other things that I wanted to highlight is going back to the social determinants. There's a window of opportunity for any of you who are sleep deprived. We are proposing to collect in our post-acute care rules data on these social determinants as a starting point. So looking at standardizing, we currently have race and ethnicity. We're updating to the current standard. Preferred language is not in all of our data. The need or desire for an interpreter. Have a single item for health literacy, one for transportation need, and one on social isolation. We chose these because these settings are largely inpatient settings as opposed to community settings. So if we were to think about community settings, we might have done something differently. But there were, in our notice of proposed rulemaking, the comment period for the first 2 closed, but Monday is the closing period for the long-term care hospital comment notice of proposed rulemaking. So you will find it in each one of those, and we do hope that people will comment because we need the positive as well as the negative to make sure that we finalize and start to move forward. But again, this will allow us through standardized way to be able to capture for the first time and to evaluate those impacts on quality, on utilization of resources, and costs. And then lastly, one of the things that we've done is we want to celebrate those who are doing well, and we want to lift that up. So last year, we started our CMS Health Equity Awards, and we did that because I personally have been tired of people saying, oh, these are such intractable problems, and there's nothing we can do about them. And so we wanted to show that, no, that's not exactly the case, because these are people who've actually provided demonstrated results. We also wanted to, again, going back to the fact that health disparities work is rarely well-funded and well-staffed, to help support those within these organizations organizations who are working on these issues. So when there's kind of competition that sometimes happens, so these individuals get acknowledged for the work that they're doing, they get more support within their organization. And we actually have had a couple of organizations come up to us and say, okay, how do we get one? And so this is not a participation award. This is about showing measurable results that have closed a gap and not simply improve quality of care for everybody, but reducing those disparities. Again, you can learn more about the work that we're doing. We are often trying to engage with patients. One of the things that we're doing is a health equity collaborative focus on reducing disparities in diabetes. And we do have a patient representative who's on there who's been a great participant, and we always try to incorporate that voice to make sure what we're doing. And with our maternal health forum, we led it off with a video of a woman we interviewed from Iowa talking about some of the challenges she had getting care to deliver her second child. So, thank you.